Right. Well, we're really happy to have this opportunity to get together with the city, or the borough, excuse me. It's still taking time for me to get used to that. And we would love to take a little bit of time to just talk about what our relationship is. I don't know if people need to introduce themselves. I don't know what the protocol would be there as they speak. I think everybody knows us. I'm Darlene Whitethorn, the president of our hospital board. You know, we're supposed to have a meeting once a year, according to the charter, I believe it is. And we have not had that on a regular basis. And so we really would like to be able to start doing that again. Our futures are tied together if this community is going to survive. Without medical services, there's not going to be much of a city left, or a borough. Our older people are going to have to be looking for places where they can move, where they can get good medical care. People that are thinking about moving to this island, you know, there's a lot of good things about it, but they're going to be, weighing the pros and the cons. What would be the best thing to do? One of the top things on their list will be whether there's a good medical service or hospital here. So we want this opportunity to dialogue with you all, to discuss how we fit into the borough plan now and in the future, both financially and politically. So I have some other things I'd like to talk about, but at this point I would like to just open it up for anyone else that may have some comments they'd like to make. Anyone? Do you have any questions about why we're here or anything like that?
No, keep going with what you're doing.
Yes.
Please.
Well, all right. The other things I wanted to bring up is you can see that there's this diagram up here, the borough department, and you're on this end, we're on this end. Are we going to continue with a standalone hospital, or will we end up going with a partner? I know a lot of people are not wanting to do that. Dr. Monica Gross did a great report. I think some of you even have it.
Yep.
It's called the Petersburg Medical Center Long-Term Planning Community Needs Assessment and Force of Changes, prepared by her. And we have it now. I've gone over it. It's really a good report, Dr. Gross. One of the things that I got out of that is there are 14 critical access hospitals in Alaska. 9 of those are affiliated with a partner. 5 are not. Those are Sitka, Cordova, South Peninsula in Homer, Wrangell, and Petersburg. Sitka is considering a partner, but at this point, they're still under the borough, or city, I guess it is for them, as far as control. So, in this report that we got from Dr. Gross, she had some statistics that I thought were really good, and I want to point those out. Sitka gets a cigarette tax from their city. It amounts to between $600,000 and $900,000 a year. In October, the Homer Peninsula Hospital, their voters approved a $4.8 million bond to fund a new facility. So that is Homer. Their voters did that. And then in Cordova, their city contributes $566,000 to their medical center. Wrangell and Petersburg do not get any funds from their borough. Now that's the financial part of this. So I just want to put that on there because I think that's kind of important to know. And those other cities, I think, are bigger. Homer is pretty close to us. Cordova might be too. I'm not quite sure. But those are pretty staggering amounts that come from them. So at this point, we're not asking you to do anything financially. Our main concern right now is hopefully you'll be supporting us. As you know, we've been talking about doing building a new hospital or remodeling. And that's going to take a lot of funds, but it's also going to take a lot of support. And I feel, and I think our board does too, that if we don't have the support of the assembly, we're dead in the water because people look up to you and your constituents. So we have to be able to promote this change, if there's going to be one, and decide whether or not we want to stay as a standalone community hospital or if we want to partner. So those are basically my comments today.
Caroline, can I ask you a question? Follow up on that? Maybe if you could, I mean, obviously in principle we want to support the hospital, but could you refine that statement to mean, what would support mean to you guys? Like, what does that mean, if you could break it down a little further?
Okay, does anyone else here that would like to talk about that? I do not want to do all the talking here today.
I'll start it. George Doyle. I think some of it has to do with the fact that there hasn't even been any dialogue between the borough and the hospital board. I think that's the first thing on the table. Why hasn't that occurred? And what do we need to do to make sure that it does in the future? And it isn't just the assembly as much as it's understanding what the community wants, or having the hospital, the staff of the hospital, they can tell us exactly what's needed. But if the community doesn't want to support it, then it's really not going to get anywhere.
Norm, do you want to talk a little bit about our situation?
In a lot of ways, Petersburg is extremely fortunate and is a bit of an outlier when it comes to critical access hospitals. Critical access hospital is a designation under Medicare, which says Medicare will reimburse you 101% of the cost of treating Medicare patients. They guarantee you won't lose any money on treating Medicare patients. Then there is under Medicaid at the state level, we're cost reimbursed there too. Since 2010, there have been 60 rural hospitals across the country that have closed. And currently there are nearly 700 rural hospitals that are vulnerable to closing. And of those 700 hospitals, 68% of those are critical access hospitals, or nearly 500 critical access hospitals of the 1,341 are vulnerable to closing. You're very fortunate. You're not among that number. And I think from my experience in the last 3 years as your CFO and understanding that reality from having worked for 15 different hospitals since moving out of education into healthcare in the year 2000, your hospital has been extremely well managed from a management level and from a board level. Your boards generally have been very frugal with spending the hospital's money, and that has translated to the financial situation that you're in right now. They have, over the years, spent money. The last 10 years, they've spent approximately $6 million in upgrades and equipment at the hospital, about $4 million of that in equipment, much of which, if you did decide to build a new facility, would go to the new facility, so it wouldn't be wasted. And just in the last 5 years, there's been about $3 million spent, and about $2.5 million of that in equipment. In the current year, the board has authorized the expenditure of close to $1 million, $300,000 for the renovation of the kitchen, and about $650,000 in additional equipment. So, and they do that not without great, consideration and discussion. It starts at the staff level and comes up to the board. So again, I would emphasize you're not in that group, that's vulnerable to failure at this point. However, my experience also says that that can change very, very rapidly. Currently, the state is looking at cutting 5% from our Medicaid. So they're saying, we recognize that it costs you $100 to provide this service, but we're only going to reimburse you $95. And then you just never know what happens at the federal level either. So I have seen situations where hospitals begin to spiral downward. It becomes almost impossible to stop that if that spiral starts to happen. Again, you're a very long way away from that. Currently, you have operating cash on hand of about 85 days. When you add all the hospital's cash resources, it's more like 164 days. So the hospital is healthy financially. In fiscal year 2016, which ended in June, you had your bottom line, positive bottom line of close to $400,000. When you add back in your depreciation, that gives you a cash flow of over $1 million. Hence, the board can use that money, going forward. July was an exceptional month. It's one of those things you don't want people to be sick, but if they're going to be, you hope they can stay locally and be cared for. So July was a very positive month. The revenue was about 10% over budget. Expenses ran about 5% over budget, but it provided a very positive bottom line. So I have to look at Petersburg in the perspective of the 15 other facilities I've worked with. I've worked in facilities that got to a point where I get a knock on my door saying, the linen guy's here, but he won't leave the linen unless you write a check. So we're very, very fortunate. I don't like those days, and I'd hate to see you get there. And again, I'm not suggesting that you're anywhere close to that. I think for the foreseeable future, it's a very positive outlook. My personal opinion would be a new facility would be excellent. We just had a conversation with Mike, our maintenance manager, this morning about some fuses that began to arc and melt together, and he was very proactive about it and could have avoided a very serious fire, And so you're dealing with infrastructure that once it breaks down, you have to begin to repair it and then try to get to a point where you can stop, So the infrastructure is poor. But again, our maintenance folks and our housekeeping folks and all the people at the hospital do an outstanding job of keeping it in good, clean, functioning repair. We talk about the funding for building a new hospital. Again, because you're cost reimbursed, if you decided to build a new hospital and you financed it in some way, you now have a new hospital that you begin depreciation all over again on. And typically a new facility, the majority of the depreciation happens in the first 15 to 18 years. And because that's a cost, and that cost flows through to Medicare and Medicaid, your reimbursement from Medicare and Medicaid are going to go up. When you add interest to that, the interest and the depreciation, whereas now it's about $600,000 a year, if you begin to depreciate a $40, $50 million project, that pushes your cost up and pushes your reimbursement up. A financial feasibility study would tell you whether or not that those numbers would kind of get close. Wrangell is going through that process now. But it'll never be 100%, I don't think. But I think it can get close. So again, the good news is you're not in danger of closing like 35% of the other critical access hospitals. But so now's the time to work from a position of strength. You know, you're not desperate. You're not looking for a way out. You now have the ability to say, you know, let's start the process. Let's take a long, hard look. Let's have the discussion while we're in a strong position, because you're able to make much better decisions working from a position of strength than a position of weakness.
So I would like to start out by saying that I think as an assembly, we're very supportive of the hospital. We understand the impact of 100 jobs in this community. We appreciate having the services here. I don't think you tell your story well enough to the public of all the different things that go on, and I've asked several times, you know, put together a public involvement plan, start telling what you do for the community so that folks recognize the value to Petersburg. You're in a much stronger financial position than when I first started coming to meetings. I think the very first hospital board meeting that I went to, I believe, was in your office, and I think you had just come on. And I believe the report was that you had 5 days cash on hand as your assets, you know, financial assets. And you're certainly in a much stronger position now. And I appreciate all your good work for making that happen. I think we're talking about a couple different things here, and we have to decide which piece we're going to focus on first. You've talked about the relationship of the assembly to the hospital, and one thing that I want to point out with the numbers that you provided, those communities do provide a lot of financial support to their hospitals. Some of those communities, I think the hospitals are not owned by the borough, and of course in our case it is. The other aspect to it, though, is that the relationship between local government and the hospital in some of those communities is very different than ours. For example, we can't sit in on your executive sessions. You have the full authority to make decisions for the hospital where we don't get to enter into those decisions. So that's something that we probably should at least say, do we want that to continue or do we want that to change? Monica Dr. Gross did a good start at looking at what kinds of use we have for the hospital and what the community needs are. But I think when we talk about whether or not we're going to have a new hospital or to refurbish a hospital, we really need to take a step back and do a really good look at what does the community need now, what does it need in the future, and what can we actually afford to provide before we even talk about what kind of facility we're going to have and how we're going to refurbish it. And I don't think anybody argues that the hospital needs something, whether it's a Band-Aid or a new building. The other thing that we really need to talk about, and we have, but we need to continue, is what kind of financing is available, what kind of financing do we need, and is it realistic now? And if it's not, what's the plan? And we should have a plan and a timeline overall. So those are the questions that keep coming up for us again and again and again. We're open to any and all discussion and permutations. I think the assembly at this point is waiting for the hospital board to say, this is what you want. Not just a new building, but how are we going to operate from this point on out? And then let's craft that, whether we need to create new ordinances or memorandums of understanding. That's kind of what we're hoping to hear from you.
Yeah. Cindy, if I could add that, when the borough was being formed, I was on the charter committee of the 11 people here. When we got into the issue of what's in the charter for between the hospital and the borough, it got fairly contentious. And at the time, the folks at the hospital wanted total autonomy. There wasn't any real arguments against, for, or so forth, and frankly, that's what's ended up in the charter for total autonomy, you know, of the hospital. Looking back on that now, quite a few years, I agree with George. Those relationships need to be improved, but how do you do that? And then do that, I think you got to change the charter. I frankly think there needs to be a different way of doing business. After I looked at that, whether it be somebody from the assembly on the hospital board, whether it be done differently, I don't know. I'm not arguing for the answer, but I do think that needs to be up for grabs, and I think that would really help the relationship. I do agree with you, George, on making some changes.
I think we have made an effort now to let people know that we're making, what we're doing at the hospital. You know, we try to have ads. I read Dr. Gross's report, and some people think that's just not adequate. And we know that that's not what it's going to take, but it's a start. And you know, we also know we have to get it out there with the community and try to change how the community feels about the hospital. You know, I know there's I know there's a lot of people that have a bad feeling about financially how we operate, perhaps some salaries and you know, this report points out what the you know, average salary is there. And so I'm hoping that people will get a chance to read that report, you all too, and that you will be able to discern also what would help us if you were to also be speaking to the public, the community about the hospital. I really agree. I think you had some good points, and so do you. I mean, Bob, I was there when that started, and it was contentious, because I felt like we were being, I don't know what to say about it, but it bothered me the way it came down.
Yeah.
And so what I hope we can do is be more considerate of everybody. You know, certainly we feel very close to our hospital, and we want it to do well, and we want to have a facility where our long-term care people are happy. And I mean, that's where we get our money. And we don't want to have to be always fixing something because this is where we're at. This is all we have. So.
And my frustration on the other side of that is that when you look at all the things we need to do, whether it be school, hospital, the infrastructure and so forth, we have a master list. And I don't know, about 4 or 5 years ago, we tried to get, you know, projects for the hospital on that list, but we didn't get a list that, you know, how do I want to say it, that was very specific with, you know, what needed to be done. So when we went to the legislature, we were arguing with funds. It's really hard to argue when you don't have the information in your hip pocket to be able to argue. You know, I don't know if that makes sense.
Yeah, it does.
And I'd really like to be in a way that we could argue for all parts of it, you know, not just one part of it. And that's some of my frustration of trying to represent everybody, you know, in that. And I don't know how to change it offhand, you know, until we look at that charter and get some agreements on it. But I agree with Cindy that it needs to be looked at.
The only other point that that causes me concern is that Wrangell is trying to find funding for a new hospital at the same time, and I wonder what the realistic, you know, likelihood is of 2 closely situated hospitals getting funding for new facilities at the same time. Really is, and maybe that there's some services that we could share between hospitals. I know our physical therapist goes back and forth between communities. There may be some other things that we could share with them, or we could peel off something that doesn't work for us but works for Wrangell, you know, and knowing that we have transportation between the 2 communities, that might make it a less daunting financial proposition for both communities.
That's a point, but Wrangell and Petersburg are in really strategically, you know, we're on an island, and it's a little bit hard to, I mean, we could get some, I think it would eliminate some costs, sure, but I don't know that it would, well, it would help, I'll put it that way.
And there may not be, but I think at least we should look at that as a possibility and see if there's some ways we could save some costs.
This is Liz Woodyard. We've explored that a lot over the last few years, and Doran is probably our best example of sharing, because Doran is
That's true.
CFO for both. But it's really, really hard for clinical services, just really, really hard. The PT that was coming over is not coming over anymore. It's just too much of a burden for them, and we share, we share equipment if somebody's out of something, but even that's either breakaway or a jet, to come and get it and go back. So we have...
Not even equipment, but I think Liz Bacon was saying you share supplies as well, don't you? I was thinking as things were getting close to expiration, you were checking between.
Well, we're trying, but if one is out, we definitely, share. But other than that, we've, I've met with the CEO and we've all met with staff there. It's really, really hard. Staff is, I would say, not feasible.
It's not a big picture solution, is what you're saying?
And I've gone over there to see a surgeon, but even that is, so sharing doctors, it's 2 days, because it depends when you can get your appointment, and then you still have an overnight stay, so then why not go to Juneau or someplace else? So it hasn't, we've really looked at everything, and it hasn't really worked out.
As far as financing two facilities, if you chose to do that, if the two communities chose to do that, unless you were competing for the same grant funds or something like that, I don't think there would be an impact really, because, if you're going to finance it, obviously the Borough of Petersburg has a limit on their borrowing authority, but as I understand it, revenue bonds don't impact that borrowing authority. I asked the manager, the partner from BDO that did our audit in August to help clarify that for me, and he made some phone calls, and that is the case. Now, ultimately, since the hospital is owned by the borough would be the one borrowing the funds and would obviously require an approval of the people, but it wouldn't impact your borrowing authority, and you certainly would need to make sure that you were 100% confident that those bonds would be able to be paid for. The cash flow for a hospital that's built new in the first 15 to 18 years is exceptional, because of the increased reimbursement. And you don't take a new facility and depreciate it over 40 years. It's broken down, it's componentized where the average depreciation is about 18. So I don't think the two facilities, two communities, if they both decided to build new facilities, would necessarily be competing for the same dollars. There are lots of people out there, that we're anxious to loan money to, to facilities like ours. They're nonprofit, so there's often tax-exempt bonds and different kinds of things that can be worked out. All that would have to be worked through a bond council, but I don't think financing two facilities at the same time would necessarily impact one another.
I just thought of something else that you said, Cindy. Jenny, would you mind speaking a little bit about the group that has been formed to discuss these, with the changes that we would like to see?
So part of our strategic plan is growth, and as such, one of our goals is to form a committee to talk about long-term planning. My name is Jennifer Reiner, anyway, so we have some board members on our group, some staff members, and some public members. So we formed this committee to just talk about what is important for long-term planning in Petersburg. And we really started our first meeting with just, why is the hospital important to you? And it was really amazing how everybody from, different areas and different viewpoints, it's all really about, we need to provide medical care for, this is our home, and our parents live here, our children live here, our siblings and friends, those are the people we're providing care for. So it was really important for everybody to have a hospital and medical services that will be there to support you when you need it. We realize, and the committee realizes, that most of Petersburg, if they have, if they come across the medical center, it's usually in the clinic, which is new and pretty, and seems great, and that's the majority of the interaction with the community. Second is lab, which is right in the door. The lab for a facility of our size has an amazing capacity to do tests that most places wouldn't do. I mean, it's a true asset. And so after that, the people who actually walk down the hall, and after that, it's probably families and friends of long-term care, residents. And those are people, we have 15 long-term care beds, so those are the people that live there, and most of them plan to spend the rest of their life with us. And then after that is if you're, an inpatient or you're sick enough to have to spend the night in the hospital. And so that's very few. Few people see that. And I guess my point is, the farther down you go and into the older recesses of the hospital, you start noticing the things that are really wrong. And so that's where we felt it was important to have staff on our committee, also the community members, because they have a different vision, and perspective. And so, so with this committee and the reports from the assessments from Jensen Yorvelot, which I think you've all seen, I mean, we know we have a problem with our facility, and it's not going to last forever. And we are afraid that one day, sooner than later, one of these major problems is going to occur. We keep having these things like sewer problems, and they cut into the sewer pipes, and they're just like, just barely there, and then they cut into other things, and it's like they don't know, they don't even make things like that. 10 years ago they didn't make those anymore, and so now we're, and the electrical system is another huge issue that's well past its life. As they built the hospital, and these are all the reports, but they kind of like, the old hospital was here, and then when they built the new part, they just added on to the existing systems. So even though the main hospital was built in the mid-80s, they're linked into the hospital that was built into the 60s. Some of that even, like some of the sprinkler systems were from like 61, which we just had to replace. Anyway, so we just know there's a problem, and the people who are working there and providing care, we're really afraid that one day something's going to go out and it's not going to be able to be fixed. And then what do we do? Because we have 15 people that live there that require the care. We have emergency patients every day. We have people who need those basic infrastructure things to do well. So anyway, we know the problem, and so then we need the solution. And that's where this committee has kind of gone and looked at the assessments, and also the needs of the facility. We have our technology, the equipment, just the standard of care. When long-term care was built, people just like literally got tied into beds. Back in the 70s and 80s. I went to nursing school I graduated in 1996, and that was just at the end of when people were like tying people down and just keeping them, there. Now we have people, we want them to have the most fulfilled life they can, and so we don't have an outdoor area. There's no safe area that residents can go outside. There's not family rooms, there's not like a chapel or a place for people to really be together with their families. There's no private meeting areas. And so all those things that were okay 30 years ago aren't okay today. And so even so those are the things, and then you talk about the acute side and just the technology changes, and even just getting beds around corners, it just doesn't work well. And so there's a lot of reasons that we are looking at remodeling or a new facility. The committee, after kind of viewing everything, voted to recommend to the board that we build a new facility based on several things. One is that we're under the 100-foot marker, so in the last tsunami warning, we had to evacuate the hospital, and we really want to be a place that people come to and not have to leave from. We don't want medical care not to be available in the event of evacuations and different things like that. We want an area where our long-term residents can go outside. There's on an equal, they have ground floor access to go outside, have a safe environment to garden or sit in the sun. And then we just need the technology and the infrastructure to keep up with where we are.
Jennifer, I don't think you have to convince us.
Sorry.
Do that with your maintenance people. You have 100% agreement that there needs to be something done. It's a question of what, and what the timing is and how much. With that said, have you had an independent analysis looking 20 to 40 years out of what the hospital or our facility, our medical facilities here should be providing, what's cost effective, what isn't, and what really should go outside or stay in? And I know your last point of what, with the communications changing so significantly, obviously, some of that stuff has to change. Has there been a look at that type of thing at all?
Dr. Gross's assessment is the first step in looking at the needs, and I think you probably saw the population, projected population, although it seems we've had some baby booms in the last several years, So we anticipate that our population is aging, and statistics show that the older people get, the more health care they need. The healthcare is changing. I mean, we're moving more towards outpatient care, than inpatient. We've actually been doing that for a long time. Our actual inpatient volume is low because we have really good primary care.
Expand on that. I think we have, over the years, done a really good assessment of services that are needed and not needed. We already are a bare bones hospital. So I think I think if you look ahead into the future, we don't need additional ORs, but we need one. We don't probably need additional acute care beds, but we need some because they can all be swing beds, and that's a need. We've anticipated that we would like to add 5 additional long-term care beds. The clinic size is adequate for the numbers of, our census has been stable over the last few years. But we don't really have services that I feel are over the top or not needed. We're already kind of a basic bread and butter hospital. And I really feel that you do need some acute care beds because if you have pneumonia, you're not going to want to go to Juneau or Seattle for pneumonia. You want to stay here. We need a psych room. We absolutely need maybe a better, secure psych room because we will continue to have patients that are overdosing or suicidal. We will need at least the one OR room because we do want to have some local colonoscopies, endoscopies, minor surgeries. But we won't ever be offering a higher level of surgeries. It's just not feasible because the doctors would have to stay and follow up with their patients. And so I think outpatient services are definitely expanding. Everything's going outpatient. Even I read this morning that CMS is proposing all joint replacements be outpatient surgeries. People can be in at 7:30 in the morning and they're discharged by noon. And so inpatient stays are definitely decreasing, but we already have a very, very low. I mean, our average inpatient is one day. So, and that's a lot of times because they qualify, but maybe they don't have the support at home. Maybe they're elderly and they don't have a spouse that can really take care of that person. But if they were younger, they probably would be home and would be on an outpatient. We absolutely have to continue to have outpatient lab radiology. The one thing that maybe in the future, depending on costs, would be adding an MRI because it is a lot of people now get MRIs. And you have to go out for that, but it's very expensive, and so it would have to be really considered. But yes, I think internally we have looked at services. It's just my own personal belief, but looking at other facilities and other critical access hospitals, I think we really wouldn't want to have less. I think I would recommend we stay with about what we have. It could be configured better so that it would be more efficient and more effective.
There are heads nodding behind you.
Yeah. So, so maybe you have one nurse's station and, or better flow which would probably reduce some cost and increase efficiency and better use of staff time. Because now, sometimes you have to have more staff because you're farther down the hall and you just can't see your patients as close. So there's things like that, I think that would come from either a remodel or a new build. But services, I feel that we offer the services that we need for a community our size.
And I agree, and the only thing I'd like to add is that with increasing technology, a lot of facilities, small facilities, are going more towards these, they call them EICUs. And so I can foresee that if we were to go that route, we would actually keep more people in Petersburg instead of having to medevac them out for care that they really could provide here with just an intensive looking over them. So in some ways, I think in the future, we may actually even be able to keep more people in Petersburg and send them out. Certainly not surgical cases, but just really sick people.
And I get that. I lived in Yakutat, and your option was a Band-Aid at the clinic or a medevac out.
And I guess as a community member, that's not what I would want to have.
And the numbers bear out what is being said. Last fiscal year, only about 16% of our revenue was for inpatient care. The rest of it was clinic, long-term care, and ancillary services. Now, some of those ancillary services are provided for inpatient, but as far as the financials go, only about 16% was for inpatient care. So any new facility would obviously focus on, like Jennifer said, long-term care, ancillary services, clinic services. That outpatient treatment is obviously where it is now and where it's going to continue to go.
Echo something Bob said. You guys need to convince me of none of this. I'm totally with you guys.
Right.
But as a follow-up, not to belabor the point, but how else can we support you? If you can be specific, I know as my role in the assembly, I want to think of ways we can be of use to you guys as the hospital board, staff, et cetera.
Right, and one thing is maybe one of the board members or the assembly members could be on that committee. That would be a start, so you would see what's being done. Bob mentioned something about maybe a assembly member being on the board. We need board members, so if someone could, that'd be great.
I agree. That's one of the first thing that was on my list was an assembly member and maybe even a staff person that sits on the building. Bob, to get back to one of the things you said about where do we start, when we looked at Joanne's first initial assessment, I don't know where you start, because as soon as you take the wall apart, you're into the electricity, you're into the tech, you're into the sewer and the water, and I mean, that's what me as a board member said, we need a new facility. I don't think we can fix this facility. The other aspect that we haven't talked about in fixing it is when we close down the long-term care section or whatever, then the finances are just going to decline very, very significantly to the point that we will soon use up all those AR days and we'll be in dire straits. And the second thing that I came up with is maybe at one point in time, I know you and Cindy, and I don't know if you went to one of the board meetings or not.
Not with these guys, no.
But I think those were helpful things.
Mm-hmm. For me, it was.
And then somehow we do have to define what the charter means.
Yes.
I don't know.
Agreed.
Well, we keep coming back to what's the relationship.
Whether the
Let's
lawyers
define
need to
it.
get together and talk about that, I don't know how that happens, but.
Well, I think we can redefine it, Tim, the way we want it.
Mm-hmm.
And then we just put it on as a charter amendment it has to go to the voters. But I'd be certainly willing, to put it out there as a charter.
Absolutely.
Sure.
Whatever we need to decide.
Can I just say one thing about that? The original, the hospital used to be run by the city, and the city used to do all the books, all the hiring through their hospital administrator and so on. There wasn't a board. There was a hospital group. In 1964, when they built the new hospital, there had been a huge outpouring of community support for that and fundraising and just all kinds of stuff. And then when they built the hospital in 64, the one that's still there, it was an addition to the older one, the board, the assembly decided to form a hospital board to take care of just the hospital, but they maintained the relationship, they maintained sort of the overall governance of the board in that they needed to see the budget once a year, and then what's in the charter now, I think, is old. You know, it came from the 1964 initial breakaway, you know, from the city. But so, and it may have been that the city didn't want to give complete control to a hospital board, you know, that they still wanted to have, because they had, since 1917, been in charge of the hospital and all of the expenditures and the budgets and all that kind of stuff. A lot has changed regulation-wise since 1964. And so I think as the assembly, well, wasn't the assembly, the council, sort of new council members, and time went by, and people just on the council and then on the assembly kind of just forgot about the hospital because they were off doing their own thing and didn't even realize that it really is a city entity. You know, it is a city organization that was very closely tied to the city. And so maybe it's not a bad time to go through the charter and just take a look. But first, I really believe that we need to define that relationship, because you want to make sure that whatever you have in the charter defines or, you know, regulates what you have decided now will be the relationship. And that's why I put this thing up here on the board. Really, you have the option to go from one end of the spectrum of having the hospital be a borough department to the complete other end of the spectrum, that it's a standalone entity that could, you know, was completely broken away from the city and just stands completely alone. I think right now we're kind of close to the standalone side on there, because we really do stand alone, but we have to, you know, the voting, our elections are governed by city charter, and we have requirements to develop a budget and bring it to you, and then also we're supposed to be meeting with you once a year. So those things are in the charter, but we really are closer to the end of that in being, and you own our building, but we pay for all of everything that goes on there, all the maintenance and everything like that. So we're closer to the standalone than being at the other end and being a borough department. So in the discussion about what the relationship is, it might be a good idea to make a decision about where we want to be, the hospital to be on that, you know, on that spectrum, and then define exactly what that means. So
I would agree with you, Kathy. The one thing I would say is what will be in the best interest of this borough in the long term, you know, not just us, but the borough. How can we best serve the people in this borough? That's what we're all looking for. Yeah.
And that's what will guide the development of, you know, this.
You know, I think the one thing, Bob, is to integrate the hospital. I mean, take a good look at what do we call a comprehensive plan. That's as far as we look out, right? And see where the hospital fits in there. I mean, I would think of things like, you know, when's the next road going in with sewer and water and electricity and all of that kind of the infrastructure that you need if you do want a new hospital. And that's going to do a couple things. One, it's going to get us sort of focusing a little bit towards what happens in the future. And with what Jenny said about, and Liz, the long-term care beds, it's looked to us for a long time that as the population of Petersburg ages, if we want to keep family groups together and things like that, we're going to have to do something to provide for those people. Otherwise, the family is going to make a couple of choices. Well, the only space I can get for dad, you know, is in Juneau. And so if you're mobile, like a teacher or whatever, then, you know, you're going to Juneau. And so somehow it's got to be integrated into what the city's doing, what they're planning, and how they look at it into the future. For us, it's really hard to look into the future because of all the regulations or federal government comes up with, or the lack of work on health care, which is just confusing the issue more and more from our perspective in terms of what reimbursement rates are going to be and things like that. Some of that kind of stuff I don't know that we can anticipate. It might be better to try and focus back on, you know, a good strategic plan, or integrated strategic plan, I guess I would call it, with the hospital and the borough. And then on something Cindy said, one of the places I think that we need support, I know that Murkowski got, I might have the number wrong, it was like $146 million for the Bethel Hospital, and then some other upgrades that went with it. So there is federal money available someplace if, if you can tap it.
Well, and I agree, but the thing was, that's my frustration with it. If we know where we're going and what we want to do, then we can go argue for those funds out there. And every once in a while, they do pop up, They would grab onto some of them. In the meantime, though, I also go back to what Jennifer said, is we got an existing facility we got to keep running. And we don't know how long it's going to be before you get money for a new one. So, and I think that Joan Lott did an excellent job. I went back and reread what she did originally. I think she's done a wonderful job of defining, what's wrong with it and what needs to be fixed. But part of that, as I see it, is what those needs, whether you need a new boiler or whether you need other things, that has to be some kind of like a 5-year plan or something like that, very specific of what we need to replace to keep that place running, while we're looking at something else, those types of things too.
Well, I would say if you wanted to solve that one, the best thing to do would be to, get your own facility people together with Mike Bobbs and Liz and try and come up with a prioritized list. But I think we have to, at least enter into that with the idea that we can fix things today, but something else is breaking tomorrow. And
yes.
And I know that since I've been on the board, my guess is going to be $2 to $4 million we put in the facility that we didn't provide raises for people, we didn't provide benefits for folks that work at the hospital. So we made some hard decisions as a board to keep the financial situation as healthy as we could and keep the building going too. So that'd be one of my other ideas, would be to put some group together that's got the expertise to look at that building and figure out, what are the priorities. Because we can put a third of the cost of the new hospital into fixing that thing. We'll probably lose revenue on the way that we're getting it done, by getting it done. And the other one would be that we're not going to end up with a better facility in the end.
And quick question, in terms of losing revenue, you mean from losing long-term care beds during that time to be
right.
And we have to remember that we live there, so there's nowhere, you can't.
No, it's their home.
You can't just close it down.
Yeah.
Absolutely.
Yeah.
Sorry, I didn't mean to interrupt you, I just wanted to clarify.
No.
But so any kind of a plan would also, if the final answer, once we've, hashed out what the relationship between the borough and the hospital is, if the final answer is a new facility, then part of that plan needs to be what happens with the old facility, whose responsibility, what are some of the costs involved as well. And I wanted to make one other point. It's really small. You mentioned the tsunami zone. I know in conversations with Sandy Dixon that that's kind of a moving target, and we're trying to work at getting that zone redefined for Petersburg, because apparently unless we had a big land failure over at Horn Cliffs, the hospital really isn't in a tsunami zone, and possibly getting that redrawn would give you some other options.
It give us other options.
Right.
Until that's done, we would feel uncomfortable about not
Right.
evacuating.
Didn't you guys go through that a few years ago in the flood zone?
That I don't know. This was a conversation I had with Sandy in the last couple of years, because they brought in some emergency consultants for mass casualty events and how can the hospital respond? Do you have enough beds? What other resources are available to us? And that was one point that came up in that discussion.
I think there was an opportunity, I don't remember how far along it was, I don't know Jody's house, but my house is classified as a riverine estuary or something like that, and I have a letter of amendment for my property. It was very difficult working with the federal government to get it. Do you have one, Jody?
Do you have any insurance that's affected by that might influence some costs for the hospital? I don't know.
Yeah. Well, I think as long as the hospital's over, 24 feet or something like that, they don't fall in the flood zone as defined by the federal government, which is just a magic marker on a map. That's all it is. And so when you tell them that you've got, and you've got 500-year-old trees in your house, or you've dug down to deadpan, and there haven't been successions of floods over time. You know, I mean, they finally gave me the letter, but it was hard to get. But I think there was an opportunity where if you took the new, I think Rick Braun was associated with it, where he could walk around on the flats around the borough's property, and you could get that redefined. They don't
We
understand.
have isostatic rebound, you're good.
Yeah, right.
I think for me, having only been on the board for about 10, 11 months, is things need to be addressed. And a year's gone by and some of the same discussion that the board's been dealing with, and now we're talking about relationships and defining where the borough is going to play a role or not play a role. And I guess I'd like to just say, I think there's a little bit of an urgency to getting this accomplished.
We don't disagree, but when you're talking about a financial obligation that ultimately falls on the borough, then we need to be clear
Right.
about whose responsibility is what.
That's what I'm talking about. No, I'm agreeing with, but I'm saying it's to understand whether or not is the community wanting to continue with something similar, the model that's been going on, or how does the community feel if it was taken over by an outside entity and not be a community? I mean, it'd be a community hospital in the community, but not having the same influence in the types of services that may be offered.
If there was ever a hope for some federal money, the projects that generally get funded on that are ones who are much further down the road in the process. Perhaps a location designated the property that the borough would commit, perhaps a commitment from the borough for helping with getting that site ready, a financial feasibility study, a conceptual design. I mean, if you're looking for federal money and it's based on what we're thinking about building a new hospital, we haven't decided yet, it's going to get a low priority over someone who's got all of these other boxes checked off, none of which are extremely expensive. You know, they're just say, we have a site. I mean, Wrangell is getting to that point. They have a site, they have a financial feasibility study, they have a conceptual design, and they're trying to get all of those to a point where Senator Murkowski, who I think grew up in Wrangell, maybe they might have a leg up. That, you know, it's the old adage of a shovel ready. You know, you need to get as close to that as you can possibly get in order to be able to go have a Senator Murkowski say, X dollars I'd like in this new infrastructure bill, which everybody has had some expectation would eventually come along in the new administration, you know, to slot in specific money, but you need to be much further along in the process.
How would you propose getting to that point?
Well, I think you can begin if you decide that you want to go toward a new facility. I think in working with the borough said, you know, can there be property? Can we get a designated site? You know, maybe there's some in-kind stuff that the borough could do, so we would commit to obviously, you know, bringing utilities to the site, road, possibly some of the excavation is going to have to be done. We'll commit to the site work. Committing to the site work is not, you know, doing the site work, but if the federal government sees, okay, the borough is committed to do the site work, you have a financial feasibility study, that cost, it's tiered. I mean, you get a primary feasibility study, and if you want to go further, there's other cost. And I think for Wrangell, its initial cost was something like, you know, $25,000 or $30,000, and the next step was an additional $100,000. But then a conceptual design, you know, from the architect. So, you know, we have the study, we think we can afford it, we have the concept, here's what we want to put on that place, and here's our borough is behind this and committed. So if you get all the parties committed, I think you can do that over time if that's indeed the way the community chooses to go, without a lot of investment.
So, having said that, we've already taken some steps in that direction, and I think that information has been shared with you. The borough has looked at some potential properties. One of the things that we're looking at, because of the location and because of the fact that we're on a muskeg, we're looking at how deep is that muskeg, what would it cost to do the site prep on that property. But I've got to back up to what is the relationship between the hospital and the borough. And the hospital board right now, because of the way our charter and our ordinances are set up, you are in the driver's seat. You need to tell us what you want that relationship to look like, and then we can work through that so that we can get to this end point. But until we have that, we really can't go much farther.
Well, I'd like to bring up something. I'm concerned about the cigarette tax. Now that, if I understand correctly, we had advocated for that, for help with at the hospital. And we didn't get any of that. Do you know why we didn't? What was it used for?
It goes into the property development fund, I believe.
It's general.
General fund. General fund.
And when the tobacco tax was first developed, it was proposed by the borough manager and myself to give it to the hospital or set up a special fund for the hospital, 100% of it, and it was voted down. And
so it went to a vote.
It did.
It did.
And the next year,
assembly.
yeah.
Correct.
Oh, the assembly, not
No, assembly
No.
was voted down, yeah.
Okay.
But that doesn't mean it can't change in the future.
And for the record, I think I supported your position, but I didn't prevail.
Well, thank you. But I mean, that would be, I'm just saying, that would be one thing that we would feel like, okay, they are behind us. They're going to go ahead and let us have that.
And we
Yeah.
tried to
Let me
get it.
interrupt you. I think the reason that got voted down is to go back to the relationship that we talked about earlier.
Yeah, correct.
When you're just handing off bucks, and the assembly wasn't willing to do that. And that was a significant vote, 6-1, I think. St. Pete was about the only one
I believe so.
there.
Oh, wait, no, did I misunderstand something? Some prior conversation? What'd you say?
Now, all I said is that the reason, when that vote came up,
Yeah,
it was the vote to not give that money to the hospital,
Yeah.
6-1.
and,
And the reason that I voted against it, along with the other, and I can't speak for anybody else, but I will vote for myself, is what's the relationship between the hospital and the borough? And if we just hand that money off and keep handing that money off and don't know where it goes,
oh, certainly.
why do I want to do that?
I understand that.
And because now I can go back, that money goes into the general fund, and we can see what happens to all those funds, the tobacco tax fund and those. It doesn't mean it can't change at some future time, but until we get that relationship pinned down and where we're going to go, I'll go back to Tim's point, how it's going to, I wouldn't be willing to, just say, hand out the dollars.
So what I think I hear you say is that we need to do something about our charter, but then we need to give you a proposal of what we would want to do with that money.
Yeah, how we're going to use it, if it's going to go into a fund, into a fund, or you want it put into a fund, for instance, for a future hospital, or if you want it to, for site, or how it's going to be used. That's where, I think, and again, I only speak for myself, the reason I didn't vote for it is I couldn't say, I'm not willing to open up the checkbook and say, here it is.
Okay, so if we had a good plan for how it would be used, which I think, I don't know how much it is, but it would be a good thing to put into a fund for future building or remodeling of a
Yeah,
hospital.
and see, that goes back to that relationship, the standalone
Yes,
and so
right.
forth.
So,
Yeah.
but even you feel that way even though you own the building? I mean, we could put it into a fund for
But-
maintenance on your
Yeah,
building.
but you could, if we handed it to you, since there was nothing pinned down, no agreement between us, you could do anything with it.
Just backing up to, I wanted to echo what Cindy said about you guys being in the driver's seat as far as that relationship. I know from my perspective, that would help me if you guys could be very specific in defining what relationship you want on that spectrum with us. I'm not saying you need to do that now, of course, but
Well,
that's something we need from you.
The hard part for
Specific as
me
possible.
sometimes to do that is
Yeah.
to go look at the comprehensive plan and try and figure out where the hospital fits.
yeah.
If we knew where the hospital fit in the comprehensive plan, it allows us to sort of focus a little bit on what the options are that are realistic and sustainable over time.
Sure.
If we don't understand where we fit in with the city's picture, then it's difficult for us to go down and say, here's what we need to do charter-wise.
Tim, how do you mean by, sorry, go ahead.
That's my chicken and egg, exactly the same as yours, but up from the other end of the perspective. So how do we get the yes, so to speak, and I'm not, I think we got to sit down and discuss that relationship. one, and then move off of that is where I'm at with it. But go ahead, I'm sorry for interrupting.
No, more or less on the same page right there. You're good.
Well, it's like considering the tobacco tax, if you do decide to build a new facility, and I think you started to mention it, was that, and if you designated some portion, if not all of that, it could all actually stay with the borough to do the site prep work, that
Put it
way.
into a separate fund.
It never really leaves the borough, but.
Keep in mind, there's only 3 people sitting here, there's 7 people.
Right. And that whole suite of people.
Right, and the fact is, if you did the site prep work and for some reason the hospital didn't get built, then it's still invested in additional property to expand on and build on. So it wouldn't be money that would be wasted,
But the bottom line is, we do value the hospital and we value the employees. And this is a difficult discussion, but it doesn't diminish the fact that we understand how important the hospital is to the community. And I think somehow in some of these conversations, we sort of drifted away from that. And I want to underscore that the hospital is very important to this community. We understand that.
That's why we didn't wait until after the election to have the meeting. No, because we know that probably what you're saying is what any board member is going, or assembly member is going to say. It's just defining where we go from here.
Absolutely.
I don't know if you'd want to do the same as Wrangell, but they have a borough council member who sits on their board. They're a non-voting member. They're more of a liaison. So they're at all of the board meetings to kind of absorb everything and get that information back to the borough council. And it seems to work well for them.
But again, you guys would have to vote on, come back to us with, if that's what you want, then we have to make a charter, we have to go for a charter amendment. And I'm okay with that, we just need to know what it is. And then the other part of that is that, then at what point do we want to change any other relationships along that way, so that when you're looking at, do you want any other involvement of say, for instance, the assembly in decisions? I don't think we want the assembly would want day to day, operating, that doesn't make sense. But, yeah, that's part of the discussion, and I'm thinking that needs, and the chicken and egg, and the circle's been running around, and I don't know how to pin the puppy down.
And I think that back then when there was some contentious talk, I think the hospital felt like the new borough was wanting to take over some of those day-to-day operations, and I think that was a threatening.
Yeah, we're not in that place.
So I think that,
No, but if you start a marijuana testing facility, I think you have an opportunity to raise resident revenue. Might help you out.
so I think that, I think we feel that people who know the business of hospitals should run the hospital, but I think, and I can only speak for myself, but I think we just want to be partners. We want to be partners in providing a strong area for healthcare in our community so we can serve the needs of the community. And I think you think that too, so I think we just need to be able to, at some point, say, okay, this is our relationship, we're partners and we're providing healthcare to the community, and then we have to nail down what does that look like, I think that's what we want,
I mean, it sounds, anybody cut me off if I'm speaking out of turn with this, it sounds like a very reasonable, maybe next step or soon would be coming up with a proposed charter change so that we can just redefine that. And I don't know how that needs to play out, but that seems reasonable as far as the next step to go to define what that relationship is going to look like in a charter change.
Or defining the relationship, then proposing the charter change.
Yeah, one and the same.
But thinking through the implications too of any changes that we make.
All of the above.
Yeah, work it through, yes.
And of course, we'd have to run that through the attorney to make sure that we're not stepping in something that we really don't want to.
Exactly.
And then that would have to go on for the next, but that doesn't mean you couldn't work on it in the meantime, but that would go up then for the next election, which would be next October, for the charter change.
Correct.
The only other thing I guess we haven't mentioned, Bob, Lauren talked a little bit about, requirements for funding and things. The report that Monica Gross just did for us is sort of the beginning of the, what do we call it, community needs assessment? That's required if you go for funding, so that's kind of where that is. I'm not saying it doesn't need more work, it couldn't be refined more, but the basis, I think, is in that document. It's on the website. And I mentioned to Chad today, Liz, I was thinking maybe you could bring a couple copies of it over. So I'd actually have the paperwork.
Yeah, I have my email, and we've got the hard copies, so thank you.
Instead of having to go to the
I
website.
just want to say quickly, that's a draft. There are some typos in that one that I've of course found, and I'll be putting out a final probably Monday next week. So, I mean, there's nothing substantially changed, but just typos.
Cool.
People, as they've read it, let me know, and so everyone
Well,
Let me, Debbie, is there anything I missed on any charter change? That's the procedure. Is there anything I missed on the charter if we were to go for a charter change?
No, you're correct. It will go up. We have to have it prepared to go on the 2018 municipal ballot.
And it's 3 readings, so it really have to start in about, it has to be done by about July in order to get on thereabouts.
Correct.
in the meantime, is there anything else we can do with, we'll have to put a proposal together of what we would like to see. I don't know, I'm just thinking.
Even down to wording changes, take what's in the charter right now, rewrite it if you want to.
Yeah.
And discuss it, we'll discuss it. I mean, that's a
Great.
good way to go about it.
Nothing precludes the hospital board from starting to put together a timeline and phases of a project, whether it's remodel or replacement.
Or combination.
You'll be that farther along. Sure. I mean, you need to do something, so you might as well work on that while we're working out this relationship, so that you kind of have a plan in place that we can understand, that we know, okay, at this point in time, 5 years from now, we need $2.3 million, and, 10 years from now, we need $20 million, or whatever. But how you plan to approach that, and that would be really helpful.
It would be tremendously helpful. That also puts us in a strong position then to help.
Ask for funds.
Yeah, ask for funds and so forth.
So let me ask another question then. How often do you guys revisit the comprehensive plan and adjust it?
We're not comprehensive, but the projects, that are out there we revisit that annually. Talking about whether it be infrastructure, replacing, that parts of the municipal building or
A capital project.
capital projects. Yes.
And the comprehensive plan is a guideline
Yeah,
to follow.
yeah. The projects list.
But not rigid, it is not,
Right.
we're not required by,
Yeah, but it's your guide, but
Right.
it's the broad path that you're taking.
yeah, fair enough.
So,
But going back to what Cindy said, if we had the type of thing that she's talking about, and we could include some of that with the projects, the broad projects plan we have, and put it in the priorities and so forth, puts us in a much stronger position to argue statewide.
It's a little confusing, just for me to hear a little bit of this, because the hospital could, I think the committee has definitely decided that a new building would be most important. So if the hospital, if we go ahead with that premise, let's just say we go ahead with that premise, we do have to pay for the feasibility study, then an advanced feasibility study, then the conceptual design, then looking at the land and how much it would cost to fill and get the utilities. And we could spend, $300,000, $500,000 on that part. That's a lot of money for the hospital board to approve to spend if, I think this is where the relationship, if we can't borrow the money to build it. Do you see where I'm coming from? And so that's this question of standalone or the relationship with the borough, because I wouldn't propose that we spend all that money unless there is a thought that one day, the voters would approve, first the assembly would approve, then the voters would approve to allow us to borrow money. If the hospital was totally on its own or in an affiliation with a system like Providence or Peace Health or something, that would be a whole different conversation. But it is a lot of money to spend to go ahead. And the day-to-day repairs, we really do put that into our capital request of this $1 million that we are spending. We really do look ahead at least for a year, and we've done the boilers, we're doing the kitchen, we're doing the things that, we know we have to do. So I think we're doing a lot of that, but it's really planning for the future.
I understand that, but even if the assembly approves borrowing money, we can't guarantee what the voters are going to do. So that may drive you to an answer that isn't the answer that you want, and that's just a, reality.
That's really true, and maybe that's some of the relationship questions that, do you understand?
I do, but
It's
there's
so
no
hard,
guarantee.
because we could continue to put money into the hospital, and we will. Of course we will. We're putting $300,000 into fixing the sewer problem in the kitchen, which of course more than that has to be fixed, but that's coming out of money that the hospital has generated. We're fixing the dryer that almost melted, so we fixed it. We got a new breaker box and those type of things. And every year, the department managers look ahead and say what's urgent. And then we bring it to the board, and the board makes that decision. And like, we're spending $1 million this year.
I think we understand that, Liz.
Yeah.
The other thing, the question I
I
wanted to
just
ask.
don't know how to go. I don't know how to move forward, I think.
Yeah,
But do you guys feel better? I'm just a little still having these confused thoughts.
I think we're stuck a little bit as far as moving forward because of
Okay.
those costs.
Yeah.
But in the beginning, the conversation was also getting the story out more to the community. That was one of the first
I think that's
things.
critical.
Yeah.
I think that's critical if
And
you
we
want.
talked about it, and I think you're working on addressing it.
We are.
Getting out, it was almost like the police report jokingly saying how many medevacs and whatever, through there on a weekly basis or whatever, so the community.
Well, I remember going through the lab and the facilities with Angela Denning a few years ago, and felt very more informed about what the capabilities of the hospital are and the professionalism of the staff. Those kinds of things are good for the public to know, and certainly positive press for you.
One of the physicians at one of the meetings that Jennifer was chairing brought up from their perspective was that long-term care is going to be very important, and not just in this community, but in a lot of communities with the aging population. So we were talking about looking 20, 40 years out. That was something that he mentioned. It's going to be taken into consideration. Not so much inpatient care as much as long-term care, because a lot of communities, when you get to bigger communities, we call it nursing homes down south, but that's basically what Petersburg's running right now, is a nursing home in the community.
And, we were talking about revenue bonds versus the other kind, and with the state's change in bond ratings, I don't know if that changes the amount of money that's even available to borrow. The other piece of that pie, or the other aspect to that question, is if we don't feel we can bond up to our bonding authority under one mechanism, we're certainly not going to want to do it on another one. We're not going to want to take an even increased debt under another mechanism. So,
And I don't think, going to what Cindy says, I don't think it'd be prudent just even as an assembly to
Yeah.
agree to use up all our bonding authority here, because we have everything. That doesn't make sense for us. But going back to what you said, even at that, Liz, you still got to put together, if you're in resolve, if you want some change, we got to put together a progressive plan, piece 1, piece 2, piece 3, and we may not get to the end result for another 10 years, but at least you have it in some sequential order that makes sense and can be followed, and we bring the public along with us.
Including the things you mentioned,
Right.
feasibility studies, et cetera. That's-
So what I'm hearing is that nothing's going to be done until it goes before a vote of the people, whether it be changing our charter.
That has to be.
Yeah. So at least we've defined that today, that you have barriers too, that you can't just tell us that you're going to support us with finance or whatever. And I'm assuming that goes for designating land. Like if you were to do an in-kind agreement with land, sewer, road.
We could set aside, you have to change the zoning, but you could set aside land.
Yeah, I think we'd have that capability.
Without a vote. or-
And the assembly has that
Assembly has
capability.
that authority.
Just
to
change
do
it to that public use.
There you go.
But then you're looking at, depends on where it is, but 1 to 2 million, my guess, in, building and putting in the roads and the infrastructure, to go with it, that would have to come from somewhere, and that'd be another part of it down the road. But again, that's part of this step 1, step 2, step 3 of what you might want to do.
Well said.
Yeah. And it depends on where it's at, and I think we've given a list of the land.
We've identified
Yeah.
at least 1 or 2 parcels that are
We
potential.
actually, Mike and I met with Carl Hickman
Yeah.
and with Borough.
Yeah.
But no, we've identified a piece that
Yeah.
was the closest to the utilities, and that had a large enough parcel for the projected needs. So, and then I think the next step was that they were going to do some measurements on the depth and landscape, and Joanne would do some studies on what it would cost.
Right.
What the
And they are looking into that
Right.
now, because that was one of the questions to begin with. The hospital had come to the assembly and said, would you give us land, but you didn't say how big. So we didn't even know what we were looking for.
Okay, yeah.
Well, I think they identified some other parcels too, but they weren't quite high enough. I think they were only at 90.
Yeah, and so that could change, but the utilities, anyway, this seemed to be a good spot, and it was big enough. There was one other parcel that, at first we were actually more interested in, but it's really
Is it necessary to go through the charter changes before a council person can be designated to be a liaison and attend hospital board meetings?
I think we could do that.
We could do,
Would that be-
but you would have to
We
come
could
back.
certainly do it informally.
Right, you come back with a formal, just a formal letter, and somebody could be designated by the mayor to do that.
You could also do a resolution, I believe.
Yes,
Yeah,
yes, good point.
put it on the next
And
agenda.
then that would come so that every time the board met, then you would bring that information back to the council as a whole.
Yeah,
And that's a good first step in terms of letting the public know what's going on,
Agreed.
because they track that.
And, visitors' views related to the agenda and unrelated to the agenda, we welcome you to give a report at any time, as well as committee, and other
bet.
reports.
Or even
It's
call and
valuable.
ask to get on the agenda.
Exactly. We'd certainly welcome that.
I have a question. What I heard you say then was the hospital board needs to develop a proposal for the relationship. So you really don't want anything to do with the drafting of that. You just want us to present it to you and you will say yes or no.
Right now,
Yeah.
our ordinances say the hospital board has full autonomy. So it seems like if you're going to change how that relationship works, it needs to come from you, not imposed by the assembly. What works for you and what do you recommend is what we would like to hear.
right. But we'd certainly be willing to discuss, because we've had some of those discussions, changes we think need to be made, but, as you're getting into it.
it could be a lot more efficient to have people on both sides sit down and talk
Yeah.
versus make amendments.
Even if we were to sit down and talk with you, just remember, it has to go to a vote of the assembly to put it on,
Then
that
vote
particular
vote.
document on the ballot.
If we came to a conclusion, you mean, or if we,
Well, I'm saying, if we were just sit down and have the discussions, you come back with a proposal, then we have to take a formal vote on it.
yeah,
Okay, yeah, that's all I'm saying.
okay, sure.
Just be aware that there may not be unanimous agreement to go forward with the way we were proposing.
So at this point, really, the hospital board needs to sit down and develop a plan for a relationship and present it to you. That's the,
That would be best, yeah, to start.
Does anyone else have any comments they'd like to make before we say goodbye? Yes.
Cindy touched on it just a little bit, but we need to keep in mind what the impact can be to the existing neighborhood that hospital is located in. what's going to happen with the old building if we construct a new building. Because you're going to have impacts on folks that own property near the hospital as well.
Yep.
And there's a major cost associated with that.
A question that keeps ringing through my mind is how much can the hospital afford to get in revenue bonds? I sent in May, I talked with the bond bank, Brian Williams, manager, and I believe I forwarded that information on to Doran, just to open the airways of you sending your the hospital's financials to them, just to get a broad spectrum of what, can you get 10 million for 40 years? Can you get 20 million? Like, that is going to mean a lot, whether you build something new versus doing something on a smaller scale. And I mean, we know how much we can bond in general obligation bonds, what our cap is, but as far as the revenue bonds, and the hospital is the one that knows their financials the best, they need to have that conversation with them.
That's what the financial feasibility study would do. They'd look in depth, going back and then projecting forward, and ask all the questions, and then they'll look at the projected cost of the facility and see what the hospital's potential for financing would be, and they'll give you a number or a range of numbers.
And who does that study?
BDO has a segment of their company that does that. I think the gentleman, Michael Congato, is working on that out of Seattle, actually.
Right, because we'd be going through the bond bank anyway, and maybe they can give you a ballpark, a range, sooner than later for free.
Well, I mean, we can do that. Their studies, it would give us a range, but it would not be sufficient to take to a bond counsel and a bond broker. I mean, it might give you a ballpark, but you need a much more in-depth study, in order to actually go out and shop for bonds.
It's complicated. I didn't realize that Medicaid could reimburse for some depreciation, so that's really interesting.
So just to be clear, on the revenue bonds, they're based on the hospital's earning capacity, not the borough's earning capacity, correct?
Right.
Yeah, so that's important to note too.
And again, I go back to the first things I said, you're operating from a position of strength right now. So if you want that evaluation done, doing it now while you're, in a strong position, you're going to see more availability of dollars.
Do you know how much it costs to do those evaluations?
The initial evaluation, I think, that BDO did for Wrangell was somewhere around in the $35,000 range, something like that. I think, I'm not suggesting anything by this comment, but I think the borough there paid half of that cost. Wrangell's a little more fortunate. They have some funds that were left over from some previous activity of trying to build a building that are on deposit with the borough that they're able to draw on for a lot of their expense. We don't have that, and I'm like Liz, unless there's a reasonable expectation that you would actually be able to borrow those funds, and going with the bond bank initially might be the thing to do, I'm cautious about spending the kind of money that it would take to do these things. But you're not going to get to the end unless you do the steps in between.
Anything else?
Well, before you conclude, I just want to thank everybody for a frank discussion. I think this was really valuable.
Yeah, thank you.
So we appreciate those of you that were able to attend as well.
And Eric, at the last minute, apologized that he couldn't make it. He got called to the field, but he fully intended to be here too.
Well, thank you again.